I knew I met all the requirements. I just knew that it was a late application, so I wasn't sure if I was actually going to get into the program. But luckily I did.
Hi guys. Hi, welcome to e-shadowing, guys. Sorry that we're a little late, but thank you guys for tuning in tonight. Tonight we have Andriana Cellini. Thank you so much, Andriana, for coming on tonight.
You're so welcome. Hi everyone. Nice to meet everyone.
Yes. So, guys, Andriana is an aesthetics PA, so she's in the field of cosmetics and doing cosmetic procedures. So, I'm excited to learn about everything that in the world of cosmetics. But first, of course, we're going to get started with learning more about her and her PA journey. So, Andriana, how long have you been a PA, and why did you choose PA?
So I've been a PA for 8.5 years. It's going to be half years this December. So I originally started my PA route or thinking about PA is when I was a freshman in college, and a fellow friend and colleague of mine, she had recommended or suggested that I look into the PA route because I was originally going in as a pre-med major. And I really didn't know exactly what major I wanted to do. So I was undecided. And a friend of mine was like, you should really look into the PA field. So at that point, I was working as a therapeutic activities assistant at a children's hospital. And we had some PAs there. And this was probably maybe like a month before college started. And my college that I went to, so I'm kind of going to give you a little bit of a background just because it connects everything. So the college that I went to, I did a combined PA undergrad program. So I finished my undergrad in PA school in 4 years. And I have a bachelor's of science in physician assistant studies. So I was still one of the programs that had that combined or I was still in one of those programs that had that 4-year PA route. And you had to know already that you were going to be in that PA program as soon as you started in that freshman year. And at that point, it was kind of like late for applications. So I knew that after I had some like quick shadowing experience at the children's hospital / just spoke to the PA that worked there and spoke to my friend, and I really researched the career in the field. I'm like, wow, this is an awesome field, or I should say awesome career. And especially for me, someone who I feel like I'm really passionate about medicine, but I also love a lot of other things, and I love the flexibility. Oh, someone said, tell Dr. Cellini I said hi. That's funny. That's my husband.
Yeah, he's like pretty famous.
So at that point, I knew that I'm like, okay, well, I have to apply like 3 weeks now. It's 3 weeks before I start undergrad, and I have to reach out to the whole entire PA program at St. John's. I went to St. John's University in Queens in New York, just an FYI. And I applied. I was probably harassing every administrator there just because I wanted to get into the program. And I knew that my grades I knew I met all the requirements. I just knew that it was a late application, so I wasn't sure if I was actually going to get into the program. But luckily I did. And that's how I kind of began my PA journey. So for me, it was a little bit of a different journey or 3.2 GPA in our math and science, and an overall 3.0 GPA we were able to make. We had to apply, and of course you were kind of not really grandfathered in, but since you were a St. John's undergrad student, you had priority over other PA students.
Okay, wow. So you found out that you wanted to do PA your freshman year. And then
Yes,
you were able to decide on that track before it was too late, because you said you had to know, as far as going from, undergrad straight into grad school, you had to decide. So you basically made that decision right on time.
Right on time, exactly. Because I guess about at this point, it would be almost 10 years ago, or even actually more, like 12 to 13 years ago, the PA profession, it was out there, but I never had exposure to it. Like any of the medical practices that I went to, whether it was, any of just my primary care, there was never a PA there.
Right.
So, and I think a lot of students can relate. They're kind of under that pre-med route, and then they find out about the PA career and or the PA route, and they're like, wow, this is something that really suits me. You're kind of able to have that medical background. You're able to be a provider. You're able to help patients, but you're also able to have a flexible schedule. You're also able to have a family, have a hobby, do something that also makes you happy. So you're not just zoned in on X amount of years going to medical school and, doing that. So I think it's a great way to kind of balance that all together.
Right, right. And someone actually said in the chat, as we were waiting earlier, that you have a great work-life balance, or it seems that way that your
I
work-life
do. I do. Family is really important to me. Friends are really important. My career is important. I also like to, I don't know, help other PA students. I like to have a little bit of a social media presence now that social media is, I guess,
yeah.
the it thing to do. And then
Your YouTube, your YouTube.
exactly. And then I started a YouTube channel. So,
Awesome. That's amazing. All right. So how was PA school for you?
so we, I have to say, coming from your undergrad was very accelerated for me. So I kind of had that already, that work ethic and that's those study habits already established prior to going into PA school. Just because we had to go through summers and we had to take a lot more credits per semester in order to make the accelerated program. So when PA school for me, the difference was that I had to, for me, when I study, I have to write down. I have to make charts. I have to write down my notes. I always had to have paper and pen. I couldn't just like have an iPad and like jot down notes. I have to write things down. So the hardest thing for me was, how am I going to write down all my notes? That's impossible with all your clinical medicine classes. So for me, what myself and two of my best friends from PA school, we would, after for each, I guess, exam, we would each split up different chapters or I should say different packets, and we would make our own outline prior to us studying. So like that night after we did X and lecture, we went home, we made the outline. That way we all had like the outline with like the key points, the star points, and then I used that as like my study guide, and like I jotted down my own notes from it. So I think the hardest for me was getting, like, even though I had a great study habits, was a new way of just like, I couldn't write everything down. That would be impossible.
Right.
So it was just trying to find that happy medium.
Exactly. So, do you remember your hardest class?
Yeah. No, I didn't ortho was like, I felt like you just had to, it was like a whole, like a subspecialty of medicine where it wasn't even like things were connected. It was like, now you have to learn all these bones
Yeah.
and something totally different. I agree.
Yeah.
Um, cards was not my favorite, although I feel like it's super important and
Yeah.
everyone should love it.
Yeah. Cardio
But
was tough too. Cardio was tough. And it's
um,
crazy that so much of the pants, it's cardio
I
too.
know.
Yeah.
Actually, on my pants, I had so much ortho and so many X-rays. I'm like, no, why?
Oh no, oh, no, I would not have done well because
That was my exam. I remember so many X-rays. I'll never forget. I'm like, really? This is what I was like studying like cardiology so much more and palm and everything else, and like ortho was like, probably going to be a few sections. It'll be okay. So
so, how did you end up getting your first job? Was it always in aesthetics, or well, I know it wasn't always in aesthetics, but how did you go about getting your first job and kind of transitioning into the work world?
okay. So originally in PA, well, during your rotations, you always get to have, for us, we had to have an elective rotation. So for me, I had so ortho was mandatory for us, and we didn't have psych during our rotation. So we had a limited amount of elective rotations. I remember it was derm, cardiothoracic, psychiatry, um, neurosurgery, and oncology. So I was in between two. I was between neurosurgery and dermatology. But I mean, I always knew I had like a some crazy fascination even prior to PA school with the skin. Like I would never forget my brother would be like, "You should really do derm. You're always looking and examining everyone's skin." I'm like, "No," but I'm like, "I just don't want to treat pimples all day." But then
You have perfect skin, might I add?
you. Um, so I ended up, I'm like, you know what? I'm gonna do derm as my elective. I figured with neurosurgery, maybe on my surgery rotation, I would have some exposure to neurosurgery. So I'm like, let me do something that's totally different that I knew I wouldn't have exposure.
Right.
So I ended up getting my elective rotation in dermatology. It was my last before finishing PA school. And I that practice was not hiring, and since it was my last rotation, I felt like as a student you have like a lot of confidence at your last rotation. You feel like you have everything down packed. You're comfortable doing procedures. And my preceptor was a PA, and we had like a couple of mutual friends, which kind of made it even a deeper connection. And she really trusted me, so I did a lot of procedures. I was really autonomous as I was PA student on that rotation. So I think I feel like your rotations really impact the feel that you may go into, just because if you have a bad experience, even though you like that specialty, it may just like deter you away, and you may want to do like another, maybe like your second choice. So coming out of PA school, I applied to every job. I think I applied to majority surgery, ER, and dermatology practices. Every derm practice required 3 to 5 years experience. I'm like, where am I getting 3 to 5 years experience? Who's going to hire me? No one. So I had contacted my preceptor. I'm like, if you know of any practice hiring, like, please, like, refer me. And so she was helping me out, but I stumbled upon a practice that was willing to train new grads in dermatology, and that practice you just have to take a pay cut for 6 months because that's your training. So I was interviewing there, and then I was also interviewing at other specialties. One being neurosurgery, actually, totally different neurosurgery and dermatology. But I was actually going to accept the neurosurgery position because I just felt like, as a new grad, I should be in the hospital. I should dermatology, and that was my last rotation. I kind of had a little bit of something, like I was seeing patients. I was able to, and my preceptor wrote me a great letter of recommendation, so I had that. So I ended up taking dermatology. I was with the practice for a year. After about a year, I was kind of feeling those I want to be back in the hospital kind of blues, I should say, just because all my friends were in the hospital as well. And I was young, and it's like you meet so many people working in a hospital, you make so many connections. So I started to apply for surgery specialty. I mainly in surgery. I knew I wanted to do surgery. I really enjoyed my surgery rotation. So I started to apply for surgery positions, and I got one in general surgery, which was even better than neurosurgery because that kind of combined plastics, gen surge, vascular, urology. I didn't do neurosurgery or ortho or OB, or we had kind of GYN surgery, so not OB, but just GYN, urology, vascular, and general surgery. And I kept my part-time derm position.
Okay, nice, nice. That's a lot of flexibility.
Right, because it was 3/12s at the hospital. So I'm like, great. I work 3/12s. I did that Wednesday, Thursday, Friday, and then on on Mondays and Tuesdays and Sundays, I was at the derm office.
Oh, nice. And how are your hours at the derm office?
On
Is it like,
Sundays, it was 8 to 12, and there were every 15 minutes was a patient was booked. So it was insane. It was packed. So I guess that kind of gave me a little bit of an edge when I was interviewing with surgery positions, just because I was able to kind of operate at a very high speed, high volume practice. So that was that. And then I did that so I did my derm and surgery for about 4.5 years.
Oh wow. You did
Then,
both of them together.
yep, I continued to do that for about 4.5 years. And then I moved to North Carolina for my husband's residency. I got accepted. I got a surgery job at Duke, but I declined it because the pay was awful, but also I didn't like the way that the PA and residents were working. I came from a very PA friendly and a hospital and and a pretty much an environment where the residents really respected the PAs and the attendings. Like we were the attendings and the residents like right hand. So the services couldn't operate without us. And when I went on the interview at Duke, it was just it was like very disorganized. It was like the PA would be rounding and the resident would be rounding, and both of them would put the same exact orders in. And I'm like, okay, there's like no communication. I don't like this. So I ended up not taking that position. And I was looking for derm, but in North Carolina, it was a very, I guess I should say, it wasn't as like derm offices weren't as PA friendly. Um, so I'm like, okay, well, I want a specialty where I'm still autonomous, where I can practice as a provider, just because I had that in my derm office. Even as a surgery PA, like I was the ACS PA, which is acute care surgery PA, where I managed all 30, like all 30 floor patients were all under me while seeing ER consults, while possibly having to scrub into the OR. So I was able to kind of be comfortable with being an autonomous provider. So I ended up interviewing for urgent care, and I took my urgent care job because I was able to. I felt comfortable with surgical patients or anyone coming in with abdominal pain. I felt comfortable with doing procedures, and I felt comfortable with doing like a lot of derm comes into urgent care, so I felt comfortable with that. Um, so I did hit the reconnect button. Am I going in and out?
No, it's fine right now. It's fine. You're
Okay.
kind of you're. It was like a little jumbled, but it's fine now.
Okay. And then I ended up doing that for about 3 years or 3.5 years. And we ended up moving back to New York City because that's where I'm from. And my husband was doing his fellowship there. This was kind of during the pandemic. So this was just recently. And I was actually offered a plastic surgery position at a private office because I kind of wanted to now. I knew after 8 years, I'm like, I was working urgent care for the time to fill in the void, while also I was shadowing as a PA at my current practice, and then I was offered a full-time position with my current aesthetics practice.
Oh wow, wow. So
That's the journey.
you've been there for about like less than a year.
I've been there for a little over a year. Yeah, a little over a year. It's going to be a year and a half in December.
Oh, so you moved like literally like at the height of COVID.
Yep.
Oh wow, wow, wow.
Yep.
So transitioning to aesthetics, you had to get like your Botox certification and
Well, I did cosmetics in dermatology. So the practice that I worked for was strictly medical, but then I knew that I wanted some aesthetic cosmetic exposure. So I ended up switching my part-time practice into a more cosmetic friendly, I guess more of a cosmetic friendly dermatology group. They have tons of locations throughout New York City, Long Island, the tri-state area, essentially. And I got exposure there. So I wasn't totally new. Also, while I was working in urgent care, there was a PA run aesthetic practice that I would go just help out, just to like shadow and have hours and just to like learn the industry. So I had some exposure there. So I wasn't totally new. It's just more of doing it now on like continuously rather than just having sporadic derm
right,
patients that transitioned into cosmetic patients.
right. Okay, that's a nice journey. That's a nice journey though. That I mean, it really was a smooth journey because you were still, you did derm throughout your career, even if it was like
Yeah,
time, and then that prepared you for a career in aesthetics.
exactly. I feel like all of my specialties kind of combined one or the other, or kind of brought everything together. And now being in aesthetics, I feel like I got the best of both worlds. Like I'm able to see my cosmetic derm patients, but I'm able to have my procedure skill set from like my surgery with doing all of our injectables and everything along those lines. Injectables, threads, and different procedures that we do here.
Cool. That's awesome. So, of course, I'm going to ask you some questions about, the day in the life of
Yeah,
being an PA, and then we're going to transition to the case study. But we just have some students asking questions. We'll answer questions in between. Someone asked, so how long exactly were you in school for? Being that you were like in a transition, your program was like brought you straight into the
yeah.
PA.
From 2009 to 2013. So just like your undergrad, 4 years.
Oh, okay. So you were able to become a PA in Fort. Wow. Okay, because you got your bachelor's. Awesome.
Yeah, yeah, yeah. So after your first 2 years of undergrad, you reapply, like you applied for the PA for the PA program. You were in the PA program, but you technically weren't because you had to still apply, and it was off. It was an off-campus school.
Yeah.
So after that, your third year of college was also your first year of PA school, which was your didactic year, and then your fourth year of college was also like your rotations.
Clinical year. Wow. So you became a PA really young.
21.
Wow, that's awesome. That's awesome. Did you like face like any ageism or people kind of like questioning your skills and knowledge?
Of course. Oh, they still do. They're like, "Oh, you're real." I mean, now that I feel like now that I say that I'm married, people think that you're older, like before when you're just young and you don't have like a significant people don't think you're like a responsible individual. Now I'm like, "Oh, like when you talk about like a family or anything like that, be like, "Oh, she's older. She's old enough to do this." But before, yeah, no, there were so many patients that like, especially in the hospital, they're like, who is this person? They look like a child.
Trust me, I understand. So, another question is, what's someone else? Is your specific job PA shadowing friendly?
It is. So, ironically, we have our first PA students rotating with us right now because I had a PA student reach out to me as to have this rotation as her elective rotation. And her program, actually, I never had this opportunity. Like our school had our set rotations and that's all. But her school allowed her to, if like to pick her own rotations, and they were able to, and she was able, her and her friend came, and now they're on their last week of their rotation. So one, we have PA students, and then two, yes, we do have pre-PA students come shadow us. It's just a little, it's a little tight. So it's not that it's, and with like HIPAA and everything like that, it's not just, okay, come for a day and see what we do. Kind of would want more of like someone dedicated to come a few times.
Right. Makes sense. Yeah, some students are asking about shadowing.
Yeah. I mean, there's definitely, they could reach out to me. I can give you my email. You could send me a resume. And if you're in the New York City area or even for rotations, had another student reach out from Boston that she may see if her program allows her to shadow or to have this as a rotation.
Oh, you're amazing. Amazing. Thank you so much, Andriana. So
Yeah.
we'll get her email, guys. If you want to, give it, have me or just, specific students contact me, or you want me to put your email now or give me an email.
Yeah, I can give them you whatever you think. If you want me to, I can give my email. I mean, please serious inquiries only. But it's Andriana, so it's Andriana at JECTNYC.com.
Thank you so much. They always are looking for in-person shadowing
Absolutely.
experience. Thank you so much for that. So, one question students had was it like difficult getting into or getting a job with a bachelor's degree versus a master's? Did you face any difficulties with that?
I didn't. I still I know a lot of my I mean, I would say I had no one really questioned that for me, even in the hospital setting. Um, in New York City, or I should say New York State, I believe if at this point, if I wanted to go back for my master's, I could. But if I wanted to get a job at a hospital, I don't think I would have trouble with it just because of my experience. I can't say, my program now is a master's program, so I think in general all the bachelor programs transitioned into a master's program anyway. But I didn't. At this point in my career, I also have a kind of a bunch of experience under my belt, so I feel like experience plays a great role over the, if I want to like search for a new job.
Right, definitely. Definitely. So, I know there's a lot more questions. Sorry, guys, but so can you tell us about a day in the life as an aesthetics PA from the minute you clock in to clock out? And you guys, she is still at work right now. She was, had a busy day with patients. So thank
I
you so
am.
much for staying
Okay.
to do e-shadowing.
No problem. Yes. So a typical day would, I so I come in. Well, I always when I'm drinking my coffee in the morning, I'll always go through my schedule. I always like to see what's on my schedule, how many patients, are they new patients, a little bit of a background. I'll go through everyone's. That's just what I like to do. I like to just know my patients a little ahead of time. I don't like to just come to work and read through and see my face sheets and like get the history there. If they're new, if they're established, have I seen them before? Has another provider seen them? So that's what I do while I drink my coffee. When I drive into work, I clock in. We'll go through all my face sheets. So our medical assistants are face sheets, which essentially have a face on it and then has the patient's name, all their allergies, their medications, their medical problems, and any procedure that they had or treatment that they had done with us, or if they're a new patient. And then also their referral if someone referred them, so we kind of know and we establish that relationship with the patient. And then just if they're a new patient, just if they had any treatments done before. After that, I will help out whether it's restocking, reconstituting different neuromodulators. Um, if I worked if I worked the day before and I did any dermal filler, I will always text all my patients. We have a HIPAA compliant texting app where we text all of our patients just to ensure that they are feeling okay, that there's nothing wrong, that there's no, severe pain or anything along those lines. If we did any like more intense skin treatments, I'll always reach out to the patients as well. So that's what I'll do as soon as I come in. I come about like 30 minutes before my first patient arrives. Then we'll kind of discuss I'll discuss with my medical assistant just if there is something that she noticed or he noticed while they were going through their client intake form or any notes in their charts. And then a typical day will kind of vary. Today I started with wrinkle reducers and dermal fillers, which is wrinkle reducers such as Botox you probably heard of, and dermal fillers this one was a lip filler on a patient that I had treated before, so it was not a new patient. And then there was a couple of wrinkle reducers. We did some microneedling. We did a peel. We did some medical grade facials or chemical peels. We did some more dermal fillers. We did more lip filler. We did sometimes it'll be some, face filler. So that could be anywhere from like the temples, it could be the cheeks, it could be the lips, it could be the jawline, it could be the chin. Some wrinkle reducers areas would be between the brows, the forehead, the crow's feet, or in lower face, Botox in the masseters, in the nose, above the lip, in the chin area, and then different skin treatments. Our practice mainly is the neck and above. We don't do any body. So, and then different skin treatments would be either medical grade facials, which are chemical peels, microneedling, aqua gold, our laser machine, which entails skin tightening, IPL, like a photofacial, a resurfacing laser, something to help melt fat on the face, mainly down over here, and tighten. And that's pretty much, and then we have some microneedling with radio frequency and other radio frequency lasers as well.
Oh, that sounds really cool. So,
Um,
what's your most common procedure you do?
Botox.
Botox. Yeah, I believe it.
Yeah, that's the most common. That's majority of our days consist of. There'll be a lot more Botox or wrinkle reducer treatments than any other treatment.
Wow, wow. Someone asked, how many patients do you see daily on average?
On average, we'll say about six, sometimes 15, 16 patients. Each patient is like every 30-minute appointment, including new consultations, wrinkle reducer, skin treatments. Sometimes our dermal fillers will be like a 45-minute appointment just because they take a little bit of time between numbing, between doing the consults, evaluating the patient, evaluating their photos, looking at their photos. So they may be like a 45-minute appointment.
Okay, so and that's from like 8 to 7 or?
My hours are 11 to 7:38.
Oh, okay, okay. That's great. So you wake up late.
So I actually really enjoy this. I used to always do like 13 to 12 hour shifts, so like 8 to 8, or even in my derm office was more like 9 to 5. I kind of like this just because I work out in the morning. I'm able to have breakfast. I do all my morning routine, and I still have time to kind of like a little more time for yourself in the morning. I'm a morning person in general. Like now when I go home, like no one's working out. No, I'm not like no one's making dinner. Like that's not happening. So I'm more of a morning person.
That's awesome. So another question is, do you do facelift? I don't think you do, but no hardcore surgeries or cosmetic surgeries. Is it just mainly like minor
Yep, it's
procedures?
minimally invasive. This is all minimally invasive. So no surgeries. It's all minimally invasive procedures such as dermal fillers, wrinkle reducers. We are starting PDO threads, which are threads. That's maybe the most invasive procedure where we're putting threads to kind of I should say, this or the lower face. That's kind of the most invasive procedure that we do. But mainly everything's minimally invasive. So no surgeries, no operating room, nothing along those lines.
And how autonomous are you?
So I'm sole provider. My practice is also founded by a PA, so we are very, very PA friendly. We do have nurse practitioners as well, and we have some estheticians, medical assistants, and then front of house staff. We are all autonomous. These just myself, maybe another provider, which is like another PA, or an MP, and our staff, which is our medical assistants, students, front of house staff, our communications team, or anything along those lines. 100% autonomous.
You hear that, guys? That's awesome. So you're the medical director or supervising physician just signs off on your charts.
Yeah, we have a mentor, and we have a supervising physician where we will always contact if there's any complication or any questions or concerns. But they're not they're not working with us.
Okay,
they actually have their own practice actually. So
wow, wow. Are they in cosmetics as well?
yes.
Oh, cool, cool, cool.
Yeah.
So before we move on to the case study, just a few more questions.
Yeah.
What are some like adverse reactions from like aesthetic procedures or getting Botox? Like what would you tell the students watching?
So there's a couple of there's adverse reactions in our field, and then there's complications.
Okay.
So I should say, could someone have an allergy to a neuromodulator or hyaluronic acid, which is in our dermal filler? Absolutely. I've never seen that. I've seen people, or I should say patients, have more of a reaction to maybe an acid from a chemical peel or even ChloraPrep, what we actually clean the skin with prior to even doing the procedure. There's also, in our Aqua Gold, we use vitamin C. So I've had patients kind of get a very more of an allergic reaction from the actual vitamin C. We also have had patients just have syncopal episodes, which is, they faint from the needles, very common. I did have someone seize on us because of just, that was the stress on their body, and they have a history of seizures. So that, we have like an emergency box here that we have if someone does have a severe anaphylactic reaction or anything like that, but I've never seen that here. And then the complications can just be, especially from Botox, another muscle is hit and causes the opposite of what you want. So let's say we are trying to relax this muscle down here and we hit this muscle, our lip is dropping. If we are injuring the muscle right around the eyes, then we go to, we're affecting the muscle that pulls our upper lip so that patient can smile. So anatomy is really important. The complication is that the actual filler can occlude a vessel. And when a vessel is occluded, that area of the face, or that portion of the face, has no blood supply. So essentially, when something doesn't have a blood supply, it dies. So that could cause tissue necrosis, or just death of the skin.
Right, but that sounds very rare, especially if you know what you're doing, right?
Yeah, exactly. These are all rare complications. They can happen. It's every injector's worst fear. But
relatively, they all sound safe.
yes, exactly.
Great. Okay, so we're gonna go ahead and get started with the case study.
Okay.
Thank you so much again, Andriana, for taking the time to answer the questions, and I can't wait to see the case study that you have. So, guys, I know it's gonna go over a little bit past 8, but I'm sure she has something great to present. So I ask that you all stay tuned and watch her case study. And if you guys have any questions at the end, she'll be here to answer as well.
These are not of my patients, but this was it's a good, the best, I should say, case study that I could present. More something that's more common in the aesthetics industry. Let me just now find it.
You can share your screen. If you see where it says slides, you'll see on your right side of the screen, it says slides. You can click the slides and add new presentation. You can do it that way as well.
So we have a 30-year-old female with no past medical history or past surgical history presents, stating that her forehead lines are becoming more prominent on her Zoom calls, and she feels as though she's looking more tired and wants something to lift her eyebrows. After full face consultation, the patient elects to undergo a neuromodulator treatment. The patient's treatment was Botox 18 units to the glabella, which is between the brows, 10 units to her frontalis, which is right over here, her forehead, 16 units to the bicularis oculi muscle, which is around the eye, and 4 units total for an eyebrow lift, which is along the lateral eyebrow. So this is the patient at rest. This is her lifting her eyebrows. This is her furrowing her brows, and this is her smiling. Post-treatment, I'm just going to lock the door, sorry,
no
while I do this quickly.
No problem.
Post-treatment, day 7, patient returns on day 7 stating that she still has movement along the hairline, full movement to the glabella, and states that her left eye felt less lifted than her right. So the provider ended up switching their neuromodulator to Dysport. Dysport has a little bit of a greater spread. It has more like a 2 centimeter spread rather than Botox, which is 1 centimeter spread. So they used 4 units to the frontalis. They retreated her glabella, and then 2 units to the eyebrow, 2 units to the right eyebrow for the lift, and 4 units to the left, as shown here. Post-treatment, day 16, 10 days after, patient complains that her right eye is pulling down. So we see this. So what's the diagnosis? It's blepharoptosis, which is eyelid ptosis. So this happens when this is essentially 2 to 3 millimeters lowering of the affected eyelid. It's a temporary complication from botulism toxin. And it could happen if it's injected too deep in the glabellar complex. So when we're injecting the tails of the brows, it could also happen when there's a migration of the toxin into another muscle called the levator palpebrae superioris, which is in the upper eyelid. And what's the treatment? We essentially give them drops to help this muscle contract, and it stimulates the Mueller muscle, which is right over here, so that the patient can open up their eye and that the lid essentially is not contracted. It opens up and essentially it's not relaxed, so we're stimulating it. This is just the anatomy of the facial muscle. So what happens, we don't know exactly what happens, but either the toxin was injected too deep and it migrated down, or when the eyebrow lift was done at the lateral tails of the brow, the toxin was injected too deep and it traveled into that levator muscle. The orbicularis oculi muscles are very superficial muscles, so you really want to stay more superficial, pretty much like subdermal blebs, like a little PPD around the eye. And when you inject the tails of the corrugators, these are called our corrugators, you want to stay very superficial and not deep, so there's no migration of product. So that's case number 1, which is pretty much eyelid ptosis. This is everyone's worst nightmare. It's really important that you just know your anatomy and you know how deep you are and how superficial you are. Next is a 23-year-old female with no past medical history or past surgical history presents stating that when she smiles, her upper lip disappears. Patient states she had a lip flip in the past and liked the results, but only lasted 6 weeks. Lip flip is when we apply, I should say when we treat the orbicularis oris muscle, which is right around here, and we put some toxin right above the upper lip to evert this upper lip so that there's more upper lip exposure when a patient or when you smile, and it doesn't kind of curl in. However, since we use these muscles very frequently, talking and eating and drinking, we can metabolize the product very quickly. So sometimes a lot of patients say that it's really not worth it just because it doesn't last as long. She always had small lips and would like to try something that lasts longer. Patient is interested in lip filler. After a full face consultation, patient elects to undergo dermal filler to the lips. She received 0.8 mLs of Restylane Kiss, and that was used to both the upper and lower lip. A bruise was noted to the center lower lip. However, at that time, she had normal capillary refill. Patient was instructed that bruising, swelling, and soreness are all normal, but for any pain to please let the practice know. The following day, the provider follows up with the patient. She informs the provider that she has a big bruise to the center of her bottom lip with some paleness surrounding the area. She also states she has some weird bruising extending to her chin. Patient sends us photos. So we have this bruise with some paleness around, and we have this reticular pattern or that weird bruising that she said that extended to the chin area. What's the diagnosis of vascular occlusion? What is a vascular occlusion? It's accidental injection of the filler into an artery or compression of that artery from the surrounding filler. It could rapidly progress into tissue necrosis, which is what you see down here. And it must be identified at least within 24 hours. Symptoms include pain, numbness, warmth to the location, and signs include blanching, some necrosis, swelling, colors purple, blue, red, white. Pattern is that lacy reticular pattern, which we see right over here. And then blisters, scabs, crust on the skin. Sometimes they could even get some sores in the mouth, or their gums when they brush their teeth are literally falling off. Treatment. 1 is warmth, rice in the baggie or a sock or a pillowcase, just warmth to give some vasodilation or some blood flow to that area. Aspirin if the patient is not allergic. Hyaluronidase, which is an enzyme used to dissolve hyaluronic acid, and that's found in our refrigerators. So we immediately inject hyaluronidase into that area. You could either inject it with a needle or with a cannula. A cannula is a blunt needle, and we can use it to kind of access multiple areas. Typically, we start with 4 vials. Each vial is 150 units. We wait an hour and repeat every hour for at least 3 treatments until we see that there's blood flow to the area. We assess the following day. Just a little bit of anatomy on what happened. So her inferior labial artery was included. The inferior labial artery and the superior labial artery are the main vessels that supply the lip. They are also branches of the facial artery, which is the main vessel that supplies the whole entire face. So as you can see, if this is not left untreated, it is getting, there's a blockage to the facial artery, there's a blockage to the labial mental artery, which is the artery that supplies the chin. Also, there is a very, very small plane when you're injecting the lips. These vessels run 4 millimeters, no deeper than 4 millimeters from the vermilion. So they could either be in the mucosa or in the muscle. So sometimes if you flip the lip, you can kind of see the actual artery pulsating. So I'll always look at that before I start injecting, just to see if my artery is visible to the eye. This is just another case. I don't know if anyone follows Lily Gnacchi. I probably totally butchered the name, but she just posted this on her Insta stories. So she is a makeup artist. She has her own eyelash company. She has a ton of followers. She went in to get under eye filler, and the following day she saw this weird bruising. Essentially, this is that reticular pattern that the other patient on the lip had. She called her plastic surgeon, and just see, like, this is a celebrity, so this can happen to anyone. I'm sure she went to a reputable plastic surgeon provider, whoever the case may have went to, but this is a possible complication. So they dissolved it. Obviously we see that this is very, very improved. She has some bruising that's totally normal, but just a little bit of anatomy about that. So we have the infraorbital foramen right here, and this foramen has our artery, our nerve, our vein, and the infraorbital artery is a branch that supplies our eyes. So if that went on any longer, of course, you're always worried about blindness. So that's essentially what was occluded and what had happened with her. And that's the end of my slideshow.
Wow, thank you so much. That was a great presentation. Thank you. I actually have some questions. The students have questions.
Yeah.
But one of the first questions.
Do I end?
Oh yeah, you can end the screen share. Yeah. Oh, perfect. So one of the questions I have, but I won't keep you too long, I promise. No. How do you determine how much Botox to inject in a certain area?
Absolutely. So there are some areas that are FDA. So with this, there are some FDA approved areas and some off-label approved areas. I like to think about it like there are medications like spironolactone, which is a blood pressure medication that we use to treat acne, and that's considered an off-label use. So typically there have been studies that are done that we know typically for this area we use about a max of 20 units, but maybe someone has stronger muscles, so we could use a little bit more. Typically 12 units around the eye. It can go from anywhere from 6 to 12 units. Here is 16 to 20 units. Here can go from anywhere from like 6 to 8 units up until 20 units. So really, it's one, how strong the patient's muscles are, how heavy their brows are, what they're trying to achieve, if they want movement, if they want expression, and that goes along with this. In their masseter muscles, typically will go up until 40, like 20, 40 units total, sometimes like 25 per masseter, so like up to 50 units. And then in the lower face, it's a lot lower. So like around the nose, the little bunny lines that we get sometimes, it's like 2 and 2. For a lip flip, it's only like 2 units per area, I should say, side. Down in the lower face, max is like 6 units total.
Okay, cool. So as far as the complications, it was really cool that you presented that, and to see what can happen within, 24 hours or even just after getting, any aesthetic procedure. So I see why you text them the next day, seeing how they're doing.
Yeah,
So,
absolutely.
right. So the student want to know what happens if not identified within 24 hours, or do most of these complications usually come on within 24 hours?
So yeah, majority of them do come on. There are some cases that you'll like I've seen like just with like other injectors or like teachers that I follow on social media or know or articles where you have delayed vascular occlusions. So essentially what happens like anywhere, our body, our vessels form collateral vessels.
Right.
So it will die, but the area may like turn black, but then you build new collateral vessels and that area gets the blood supply from those new vessels that form from the collaterals. So although they may have to undergo like wound care and all that, it's not like it's, I should say, at the end of the world. If a portion of the skin is necrosed, what's kind of more nerve-wracking is if somewhere in the temporal artery gets occluded. We don't inject filler in the supraorbital or even in the nose because the risk of complications doesn't outweigh the benefit. So this is a very, very vascular area. This is very, very vascular. The angular artery can lead to blindness as well as the supraorbital artery that leads to blindness. So we try to be more safe about them, about like especially whatever you feel comfortable with. Like our medical director will do nose filler, but none of us do. And then that being said, if you don't recognize it, the patient may know, like, because they may start to get those scabs or the crusting and so forth.
Okay, that's awesome. That's amazing. Well, your explanation.
Thank
So, do you
you.
have a favorite procedure?
I love I love building up the face. So I'm like crazy about symmetry. And although our face the two sides are more like sisters and not twins. Remember, I always tell my patients there was like a Snapchat filter where you can put like the two sides together and it looks very, very, very odd. I really like building up like the face, whether it's creating cheekbones for someone or a jawline or helping them slim their lower face. So I love a lot of facial dermal fillers more so than, although it's more common that we see on social media, especially is lip filler, but I love more of building up the face.
Okay, righty. And last
Yeah.
question for the night, guys.
Or just getting your preventative Botox so the lines don't become deeper and more stagnant. Once they reach a certain point, there's no way to help soften them. So really, it's not that it ages you quicker. As you get older, you may require less just because you have atrophied that muscle a little bit more. But I wouldn't say it ages you. Of course, there's a lot of bad aesthetics out there. So really, a lot of, especially in New York City, everyone's like, I don't want to look like I live on the Upper East Side where I'm like completely frozen and my eyebrows go like this. I'm like, no, that's not our aesthetic. But everyone's aesthetic is different. So so it's kind of, I don't know, Van Gogh and Picasso. Like some people prefer one versus the other. So some patients may like that aesthetic and other patients may not. So
Right, right. So, thank you. It's almost 8:20, guys. So well over the hour, but this was a really no. I just say that because of you, because you have to
that's
go.
fine. That's fine. I'm gonna be. I didn't even realize. Wow, it is. I started a little bit later. My apologies.
Oh no, you've been great. This has been so informative, especially for me. I'm sure for the students, but I learned so much from your presentation and learning about what you do. So thank you so much for coming on again.
Of course. I mean, if anyone has any questions, you could always feel free to reach out. But I feel like the best advice, especially as a new grad, is if you like a certain specialty, definitely try to get a rotation into that specialty. I really enjoyed my path of having exposure in a lot of different field in medicine. Just you grow as a provider and you learn so much working in the hospitals and being as an urgent care PA. I was the sole provider as well. I was 100% autonomous. No other provider. It was just me in the clinic. So anything that came through those doors, it was on me. So you grow so much and you become so much more competent as a PA. So it's really, really nice that like we are able to kind of have that flexibility of doing different specialties, especially if you enjoy one more than the other. You can always have the chance to do it like some point in your career. So yeah,
right? Like being able to do derm and neurosurgery
I
at
know.
the same
No,
time.
I was a crazy 21-year-old. I worked in crazy hours. I'm like, you're young, you make money, and that's what you got to do. So
Right, right. Now you're so knowledgeable.
I feel like it really molded me into the provider just because then it like builds my work ethic. So
Right. Thank you. This was
no problem.
great. Awesome. I love seeing like this side of the PA career, like the cosmetic
Yeah,
side.
I mean, this is a totally unique. It's not like, it was actually very hard for me to make the transition because it's not like, okay, well, the like, you have a UTI patient and the doctor came back and it's not sensitive to this antibiotic, so we have to change an antibiotic. It's a totally
Right.
different, there's no like study that E. coli is sensitive to this and sensitive to that. It's just like a totally different portion of medicine where you can't really you learn, but you have to have a specific eye for
Right,
this. So, so that's that.
right. Thank you. So guys, I'm gonna put her Instagram. It's her first and last name, right? Andriana
Yep.
Cellini.
Yep.
And she has an Instagram, YouTube. She has a great YouTube, you guys. It's her first and last name as well. So make sure to follow her and follow her YouTube. She has a lot of great information for the PA community going into the PA career and advice for choosing different specialties. So yeah, make sure to follow Andriana. And once again, thank you, Andriana, for coming on.
Thank you for having me. This was so fun.
Yes, it was great to have you and learn from you. So hope to have you sometime in the future and stay connected. So thank you. And
Absolutely. If you wanted to ever discuss any other specialties, I am more than welcome to discuss them.
perfect, perfect, perfect. Great. So guys, we're ending. We'll see you guys next Monday. Thanks again. Have a
Okay.
good night, everyone.
Bye.
Bye, good
Good
night.
night.